to the ZERO's Prostate Cancer's Health Equity Symposium. I'm Dr. Reggie Tucker-Seeley, Vice President of Health Equity, and I've been so excited for this session all day. It's our Ask Me Anything segment, and in this segment, we have 3 doctors here to answer your questions, and these doctors are true friends of Zero. 2 members of our Health Equity Task Force, Dr. Stanley Frencher and Dr. Joseph Osborne, and a leader of one of our US2 support groups, Dr. Sanford Jeames. Our goal with this session is to provide an opportunity for the audience to ask questions that spans from the community to the healthcare delivery system, back to the community. And so thank you, gentlemen, for joining me today. And I'll give a brief introduction to each of our panelists. First, we have Dr. Stanley Frencher, who is the Medical Director of Surgical Outcomes and Quality at Martin Luther King Jr. Community Hospital here in Los Angeles. We have Dr. Joseph Osborne, who is the Chief of Molecular Imaging and Therapeutics, Professor of Radiology at Weill Cornell Medicine and attending radiologist at New York Presbyterian Weill Cornell Medicine in New York City, and Dr. Sanford Jeames, who is a Project Advanced Facilitator and College and Career Advisor, an adjunct professor based in Austin, Texas. So gentlemen, welcome.
Thank you.
So,
thanks for having us.
Yeah, so I wanted this conversation to really be to answer some of the questions that folks in the community might have, but until we get those questions, I've put together some questions here to get us started. So if you were able to see our first session, that is our session on what is health equity, you may have seen the video that we showed. And one of the things that we asked for providers was to be trustworthy partners to Black men as we are navigating the healthcare delivery system. So I'd be curious to hear, what does it mean to you to be a trustworthy partner? Because we at Zero are also working to be trustworthy partners. Or I actually have a little Post-it note, on the side of my desk that says, what does it mean to be trustworthy? And I have 3 things listed: to be competent, honest, and reliable. So for me, that's what I'm taking out to the community, to be trustworthy partner. So what does it mean to you to be a trustworthy partner? So let's start with Stan.
Yeah. Again, thanks for having us, Reggie, and I really appreciate the time to chat with you all. I think that when I start to think about being a trustworthy provider, I have the benefit of growing up with one as a physician who was my dad. And so he was someone who practiced in the city of Detroit, grew up taking care of patients from a Marcus Welby throwback type. He took phone calls from every patient. He visited them at their homes. He knew multi-generations of families. And I think that, so I start there. I think first and foremost, we have to listen to our patients and be their physician. In the broadest sense of the word. In terms of listening and being culturally humble. I think humility rather than competence is kind of where I start, meaning that we can't know everything about every person that comes through the door, but we can listen, and we can understand where they're coming from. And I think that a big part of that is not making assumptions. Even as a Black urologist, I need to take time to listen to each one of my patients to understand where they're coming from, because my experience may be very different than theirs. And so I think that that's where I start in terms of building trust, is listening, being humble. And I think the third piece for me in terms of being a trustworthy provider is really spending time in the community. So staying within the 4 walls of my clinic is not the way to do it. And so I think really, we started first by doing a lot of community outreach, working in barbershops, even though I don't go there as much for myself. I still take my son and enjoy the dialogue in the shop. And I think that that's a place where men trust the environment. They feel comfortable. They will question me more in the barbershop than they ever will in my clinic. And I feel like the questions that I get there are more pointed, are more real, and allow me an opportunity to dialogue in a way that I can't do when I'm wearing a white coat sitting in the clinic. So those are the things that come to mind for me when I talk about being a trustworthy provider.
Okay, great. Thanks for that. And I too have not been in the barbershop in a very long time, so I understand that completely. So next, Joe, what does it mean to you to be a trustworthy partner as a radiologist?
Well, once again, thank you very much for having me be a part of this panel. And I would have to echo completely the views of Dr. Frencher, because, one of the times, and this is sort of separate, During the beginning of COVID, I actually would walk to work. I'd walk down my block, I'd walk all the way down to Cornell. And I actually had to start leaving earlier because I'd run into people in my community who would say, like, well, what am I supposed to do about this? What am I supposed to do about masking? You know, go by the barbershop, which I also haven't been recently, but they'd be like, oh, you haven't been around for a little while, but what about this? What about that? And it's actually on that walk through the community that people ask you a lot of questions that they may not ask you within the walls of the hospital, right? And so it's having that authenticity of being a part of when they ask you, well, are you getting this vaccine? Or, oh, you just turned 50. Did you get a colonoscopy? You know, or did this happen? And you're able to answer affirmatively what you would do in your life, what you would do with your parents, what you would do with your children. And then people trust that what you're telling them is exactly what you would tell your family. And when that happens and you're a part of it, really a part of the journey, that's when the trust happens.
So, I mean, it sounds like the key message from both of you is you have to get out of the clinic. You have to get out into the community in which you're working, which I think is a great transition to you, Sanford. I'm curious, what does it mean to you to be a trustworthy partner working in the community, working with prostate cancer survivors?
Reggie, first of all, thank you so much for having me be a part of this panel discussion. And I have to basically reiterate the same conversations that Stan and Joe said. Trustworthy, first and foremost, means you have to be present. And what Joe described about the experience of the pandemic and people seeing you in a different setting, as a cancer support group facilitator and population science guy, one of the best things to do to create this sense of trustworthiness is reliability. And so my experience is you have to be present in the community so that our prostate cancer, not only survivors, but caregivers as well, know that, my goodness, this individual is actually not separate. In healthcare, as it relates to equity, the best thing that we can do for patient care is to have people understand that we are actually present, we are part of the community, we are not actually separate. And what Stan mentioned about the white coat is a very good example. The white coat separates us. It kind of exemplifies an elitist type of status, and that actually creates barriers. I love the example Joe gave about walking to work. People now see me in different settings, being a population science guy. I don't need to tell you how many church services I've gone to, Bible studies that I've attended, and the barbershop is a very good example. The saying goes, you know, you go to a barbershop and you stay around long enough, you might get a haircut. One of the most important things you get is knowledge, camaraderie, collaboration, and more importantly, trustworthiness.
Yes. I haven't been to a barbershop in a long time, so I hadn't heard that in a while. That is hilarious. If you stay around long enough, you might get a haircut, but if you're there, you're definitely going to get some knowledge. So, so my next question is really about inequitable care. So nobody thinks that they, as individuals, are providing inequitable care, but inequitable care is happening. So what challenges do you as providers, so this will start with Stan and Joe, what challenges do you as providers encounter in providing equitable care to your patients?
I'll go ahead and follow you, Joe.
Okay, so, well, I'm a radiologist, so to a certain degree, we're physicians for other physicians, right? So they will refer people to us, so we get whoever sort of comes. In some ways, when you're reading scans, you have no idea who's who on the scanner. You have some hints by the name, but you're not, entirely sure who's there. I think for us as a radiologist with other providers, when we have groups where we do prostate cancer with urologists, radiation oncologists, and pathologists, it's a challenge to the other physicians. And it's a challenge that doesn't have to be confrontational, because I mean, these days we all have the numbers. Everybody's about AI and the numbers and what's happening. And so we could very simply say, like, okay, so why don't we do this? Let's look at what's happened the last 6 months with all the providers in the room, and break everything down by race and ethnicity, and whether you offered a PSA test. Since everybody is like not biased at all, no one's gonna worry about how these results look. And in fact, we could do something where we do a look back for 6 months, and you get your data. But after 6 months, we do a look forward, and then we all see each other's data, right? And so, because the numbers don't lie, right? So someone could say like, oh, I treat everybody the same, but when you start looking at the graphs, it might look a little bit different, right? Mm-hmm. And without saying specifically, hey, when you look at your PSA and screening data, it looks off. It is what it is.
Mm-hmm. Mm-hmm. Yeah.
I think from my perspective, I put it in a few different buckets. So there's the kind of individual, like, physician, allied health professional, nursing kind of factors as it pertains to how we treat patients. And then there's the systemic ones that are related to structures that lead to some of our challenges in providing equitable care at the point of service. And so first I'll start with like the bucket of providers. I think first and foremost, we all share implicit bias, like, me included, right? And so I think that when a patient is sitting in front of you, you need to be aware, and so there's ways to do that. There's, physicians these days, we get training, we take tests to understand what our biases are going into being a provider now. And I think that that's important, like in terms of addressing that as a potential challenge. And we have potential solutions, like you can know what yours are so that when walking into those situations, you can check yourself when a patient is in front of you. I think the other piece is the challenge that's created from the structural problems that we see. And so that's more to the point of when patients have challenges with navigating the complex healthcare system, challenges with insurance status, challenges with affordability of the care that we can potentially provide. It shifts the way we take care of those patients. It just does. And I think that because it's challenging already to take care of patients, we look at all the burnout and challenges around physicians, in maintaining a practice and maintaining their own wellness. That translates to a physician trying that much harder in complex situations where patients don't have necessarily the means to even provide them with equitable recommendations across the board. So I think there's those structural problems that we have to address that impacts the way physicians take care of patients. And then there's of course implicit bias. And I will not leave off the table that there still is racial discrimination that occurs at the point of service. And we continue to have to be able to root that out, to Joe's point, by understanding the data, providing feedback, and when necessary, addressing those kind of issues directly. And I'll leave one more point. I think in terms of the things we can do as family members and as patients is we do have to promote advocacy at the point of service. And so having some understanding of the healthcare system, allies to assist you in the process of getting care are ways to think about the challenges that we face and that you will see.
Yeah.
Yeah.
And
I would say
Joe?
Even one other thing structurally, with barbershops that are open all weekend and closed on Monday, our health systems have to say okay, well, many of these patients work all week, so why aren't we able to screen people on Saturdays, right? Or Sundays, or why isn't that? Maybe we can bring the PSA screening to the church or to the barbershop or to other places, because we know these are barriers that it's silly to say come in Wednesday on a Tuesday when we know these people who are our patients are still working, because if you have to work 5 days to barely pay your rent, you're not going to take Wednesday at 2 p.m. off, which is basically the whole day. It's not going to happen. And so we have to make sure that the hospitals are providing these things because it's actually necessary to do things differently.
And so my question for Sanford is focused more so on what can patients do when they are encountering inequitable care. So what can, if this has come up in the support groups, or if you have any strategies for how can patients advocate for themselves when they are encountering what they are perceiving to be inequitable care?
Reggie, that's a great question, particularly around the idea of patient perspectives and inequity. And I'm reminded of a conversation I had. I facilitate here in Austin, Texas, a gay men's prostate cancer group. And the first thing that one of the men told me, Sanford, it'd be nice if I went into a urology clinic and they had a rainbow flag. They had something that was symbolic when I walked in, and it would tell me that they are actually being considerate of who I am rather than beyond my diagnosis of prostate cancer. And so in answer to the question about what can people do, particularly providers, I think the first thing we have to do, and it goes with what Stan was saying too, we have to recognize and acknowledge our implicit biases. But more importantly, once we acknowledge it, we have to be considerate, and we have to be humble enough to say, something, I don't understand inequity, and I'm being mindful of our healthcare system, which is a healthcare system that was not designed and created to provide equity care. It was designed to simply it was designed to provide care. As it relates to inequity, I think acknowledging those inequities, that is the first thing. And then I would say this and end it this way. I think patients themselves would love to hear a physician to say, in terms of a diagnosis of prostate cancer, they would love to hear a physician, urologist, oncologist, medical, it doesn't matter, to say, something, I haven't seen this before. I don't know. I don't understand. Let me consult with someone else. And I think inequity begins to get addressed when we actually collaborate with those of us who actually have been able to go through the necessary training to actually provide equity care in terms of acknowledgement. And I say this from the perspective, I have a PhD. I'm not an MD like these other two gentlemen, but the thing about it is I recognize as an educator, people love to say, I don't know the exact answer, but I can actually find out. And so I think inequity, particularly around providers and patients, and I'm reminded again, in my support groups, we hear a lot of people in the support groups to say, I don't mind when a physician and oncologist say, I'm going to get a third opinion. I'm going to get another opinion because I don't recognize it. And I'm going to say one last thing. One of the individuals in my prostate cancer support group was diagnosed with something called ductal prostate cancer, which I know that you all understand, but the initial urology consultation that this individual got, the urologist say, I don't really know what kind of prostate cancer you have because your PSA is only 1, but you have this nodule in your prostate and you're having other symptoms. So in terms of the PSA, that's only one indicator. Mm-hmm. We have to acknowledge the fact that there are other things that need to be considered as it relates to a diagnosis of prostate cancer. And that to me is what patients really want to hear, is that providers will say, look, I'm truly concerned with your prostate cancer diagnosis, and I will make sure that we address it holistically rather than, okay, this guy's here, I'm going to provide standard therapy because this is all I do.
Yeah. So I want to give the providers a chance to respond before I go to my next question.
Yeah, if you don't mind, I think Sanford nailed it. I mean, I think that one of my biggest passions and one of our challenges of the healthcare system is the inequitable variability of expertise that's out there. So to your point, Sanford, Like, just because you met a urologist doesn't mean you met a urologist who has fellowship training in cancer urology. Doesn't mean that you met someone who has been trained in all of our most like advanced techniques for managing advanced prostate cancer, for example. Like, and the facility where you may be receiving your diagnosis may not be a place that works in a multidisciplinary fashion, as Sanford has aptly put, where physicians of multiple specialties, oncology, radiation oncology, urology, like, are all working together to come up with a decision around some of our more complex prostate cancer diagnoses. So to your point, Sanford, I couldn't echo what you said more in terms of understanding who and what physician you're dealing with and what level of expertise is available to you, and seeking those additional opinions or seeking what we call quaternary or tertiary care at academic medical centers, cancer centers, when necessary, is really, really important, because one urologist may have a niche expertise that's not even related to cancer, given the complexity of how healthcare has evolved.
Joe?
Yeah, what I'll say, because I also believe, Senator, you really hit on something. As a radiologist, as I said, I'm a sort of a secondary provider, but I've gone to a number of the support groups, and what you come away from as a provider is the variability of how people will treat nearly the same thing, right? Mm-hmm. And so one of the things that's important is to one, have the community of people in the support group support one another, but also for them to hear that it's really okay to ask for another opinion and to really figure out where they are in the broader scheme of things, because it's really hard. We have so many potential treatments. It is way beyond many providers to know even 80% of them, right? So asking around and being an advocate is extremely important. Even people who do ask, it takes them some time to find a place where they're comfortable with what is happening with their bodies, where they're being told, that, because I tell people when they see a provider, if a provider doesn't say, oh, this is what I'm doing, but you could ask around, it's fine. If someone says, no, you don't need to go anywhere else, that's the provider you need to leave immediately, right? Because there are many opinions. And if someone thinks that there aren't, that's someone you don't need to stay with.
And Reggie, if I could just add one more point. I mean, I think that when, certainly my father was diagnosed with cancer about 2 years ago, not prostate cancer, but a rare form of multiple myeloma. And I provide that example because, the challenge was many physicians we spoke to, and I'm a physician, didn't know necessarily how to treat this disease, like even at, very well-known institutions. And because there's so much variability in how to treat these rare forms of cancer. What it proved to me was that it's important as a family member, as a caregiver of a man with a new diagnosis of prostate cancer, that we need advocates with us. That could be a friend, that could be a support group member, that can be a spouse or partner. And I think that those additional ears and eyes are critical in terms of holding us as physicians and nurses and staff accountable. It's also important to leverage those support groups and other organizations to know what types of questions to ask going into those conversations. When a patient comes to talk to me about a new diagnosis of prostate cancer, that's a 45-minute visit at a minimum. And we're going through detailed questions, options, and I still end every discussion the same way. I'm not a used car salesman. You don't need to decide today. The deal's not going to change. Go home, digest the fact that you just found out you have cancer. Digest the fact that there are a lot of different options for you to sift through. Talk to your family, share the news, reach out to people who've had the disease, understand what their quality of life was after therapy, and then come back and talk to me. And if you want to talk to others, that is perfectly fine as well. Here are the names. of half a dozen people I trust and who I would have treat me. And if you're getting that kind of information or that kind of encounter with a urologist who's usually the one giving you that diagnosis, then that's someone that I believe you can trust and that you can work with moving forward.
Well, I was glad to hear. Yep, Joe.
Yeah, and it's the urologist giving many of those starting those difficult conversations. But as someone who's sort of looking into the bubble, it's always the wife or the husband right next to them, scrolling things on a pad, who's really able to hear it. They're able to hear it and process it and write notes. And a lot of times the patient who's hearing it, they can't hear anything, right? It's just too much for them to hear at one time from one person. So I'm always happy to see that other person in the room, the wife or the husband, who's the one who's really making all of the key connections while difficult conversations are happening.
So I was glad to hear you need to have either another person or another resource, because I can't tell you the number of times I've heard from men who weren't familiar with ZERO. I wish I would have known about you when I was first diagnosed to sort of help me navigate this, because honestly, this sounds like a really heavy lift, of the things that we are expecting patients to navigate after they have then been told that they have a cancer diagnosis. I'd like to get back to the point about what we want providers to do. And so I'm reminded of Joe's discussion around, if we present them with data around this is your practice patterns, and if your practice patterns are so far out of line from your colleagues, maybe that will sort of shift some behavior. And it's reminding me of the conversations that we're currently having in the health equity space, where I am terming it health equity fatigue. That is, for some people, they are getting tired of talking about it, and they didn't have to think about this maybe 10 years ago. And now we're adding another thing that they have to think about in terms of how they do their job. So how are providers, sort of now grappling with being expected to be health equity champions, where maybe even 5 years ago, this wasn't something that providers were being asked to do?
I want to start off with this kind of statement, and I'm really glad, first and foremost, that we're having conversations around equity as it relates to particularly prostate cancer. And I think it goes without saying, and Stan touched on it earlier, it is such a necessity today to acknowledge the fact that inequity has been occurring in the cancer space for so long as it relates to prostate cancer and Black men. My goodness, is even longer. I've been doing this work now for over 20 plus years, and I'm reminded that when we first started, and this is how old I am, there was a desire to address health disparities coming up to the year 2000, and there was something called Healthy People 2000. Then it became Healthy People 2010, Healthy People 2020. We changed the name to Health Disparities. And I have to say this, if we are truly intent and desire to address cancer inequity, we have to acknowledge structural discrimination, racial biases, and implicit biases that are part of the structures that all of us reside in. My formal education was an education of assimilation. It was an education of, okay, keep your head down, don't complain about anything, but more importantly, we are going to make sure that the healthcare system will have a funnel effect. Maybe people come in a wider perspective, but in the end, we want everyone to be the same. That is not a truth. Here we are in the 21st century. Individuals who come into the cancer space are not the same. Joe and Stan have all touched on the fact that prostate cancer is a different diagnosis for every patient. As providers encounter patients who are diagnosed with prostate cancer, it is so important to acknowledge the fact this individual's diagnosis of prostate cancer is not the same. Therefore, if we truly want to focus on patient outcomes, we have to also acknowledge the fact that everyone is different. Therefore, their regimen of treatment needs to be applicable to their diagnosis. And I'm reminded one last thing. I was actually interviewing or talking to a clinical director for a comprehensive cancer center, and this is a regional cancer center. And I asked the question of, how do you address clinical trials and patients who are seeking clinical trials for their diagnosis? And the individual informed me, we don't do clinical trials in this facility. We never mention it. So there is an equity, whether you're Black, white, Asian, doesn't really matter. If the clinical cancer center director says, we don't mention clinical research trials because we don't offer them, there's inequity. So I just want to point it out that way. We have to acknowledge cancer is different. It's almost like every person has different fingerprints. So therefore, we are unique individuals. Therefore, a diagnosis of prostate cancer is different. So I should not be offering everyone the same regimen just because that's all I do. Joe said it eloquently. We should recommend you may want to see someone else because this is the most important decision that you're going to make.
Yeah. Joe or Stan, about that issue related to, this new aspect of equity that we are asking providers to now think about, that they had not historically been, that's not historically been part of training, but also practice.
Well, I think it's important to acknowledge that these disparities of which we speak, just like Sanford said, if you look at the data from 2010, 2000, 1990, it's the same thing, right? You see the same, twice the incidence, twice the mortality, it's the same thing. So if it's not that people haven't cared, it's not that people haven't pushed, it's that certain things are not right that we at least have to address, right? Mm-hmm. And so I also spoke recently with a cancer center director, and he said, because he decided to push me because I'm a radiologist. And he said, if you look at all of the centers around the Chicago area that are certified by the American College of Radiology, they're all in the places where the breast cancer mortality is the lowest, and none of them are the areas where they're Black women, right? Like it looks like the opposite. So he's like, all of the hospitals and all of the imaging centers are in the wrong place, right? And so if people are staying within that imaging center, they're not in the place where the cancer mortality is. And you're like, okay, well, this has to be a part of our practice. I mean, yes we're being pushed as physicians. Burnout among radiologists is extremely high, but there has to be a way to preserve ourselves, but also change practice because it's an imperative.
Yeah. I mean, from my perspective, it really comes down to support of our providers and clinicians to do this needed work. So when we started talking about quality in the early 80s, like, sadly, it wasn't a big topic before that in terms of the quality of care that we provide. Like, we talk about metrics, we talk about providing data, but we also have to talk about creating the systems that we as physicians work in such that we can accomplish these goals. And so the same with equity, like, it needs to be a part of the broader dialogue about how we construct the systems that we work in from the beginning. So, and so for those that are already constructed, we need to deconstruct some of those systems, and reimagine how we take care of patients such that they get the resources necessary for them to get the outcomes that we intend for them to have. Meaning, all types of care, be it the variability in the cancer and the individuals themselves, but also the variability in the lives that our patients bring to that treatment decision. So the work that they do, the places they live, the families that they have in support of them, or the lack thereof, are critical to understand and address at a systems level, such that physicians aren't left to alter their treatment paradigms based on the types of patients who are coming to see them. To make that concrete, I work in South LA. And so, the idea is that I am able to deliver the same care as a UCLA faculty member, which I am, that I would provide in Westwood, that I could provide in Compton. And the reality is the only way for me to do that is not what's between my two ears or not the way my hands work, but the systems in which I practice have to change the way that we embrace and the way that we care for patients. And so as physician leaders, we have to take a role in advocating for that change and making that change happen. So I would challenge providers, urologists, radiation oncologists, radiologists, oncologists in communities where they practice, where their patients are predominantly men of color, are Black men, to alter the way that those systems care for us in order to ensure that we have equitable treatment.
Reggie, can I add?
Yes.
Yeah, I just want to add one last thing, and Stan touched on it a little bit when he was talking about, just understanding what's going on. It is so important to build on what he just said. Physicians, providers have to take it upon themselves also to be cognizant and conscious of ongoing research and advancements that occur. And I collaborate, of course, with community oncologists that may not be at an academic center. And it doesn't mean that, you cannot learn new things, but I think that's part of the issue too. Providers have to acknowledge the fact that, my goodness, education is an ongoing life learning experience. And, just because you went to medical school in 2005, it doesn't mean you don't need to continue to educate yourself around the ongoing advancements in prostate cancer. And lastly, one of the individuals in my support group just the other night, he was recently diagnosed with prostate cancer, and he was talking about the fact that he says, I heard that they want me to take another PSA blood test, and it's a different kind of PSA blood test. And he says, I don't understand why they want me to take it, because I already had a biopsy, I have a diagnosis of prostate cancer. And I explained to him, this is great because now you're actually going to learn more about your diagnosis of prostate cancer rather than a traditional blood test. And it goes and it's aligned itself. Now we need to have providers to really advocate for our newly diagnosed people. My goodness, why not recommend a genetics test to also understand more about the correlation between prostate cancer, other cancers that might exist in your family, particularly we know about breast cancer and BRCA, but especially now, that's how we can actually help our patients.
So what I've loved about this conversation is that everyone has raised the issue that we have been really talking about throughout the day, and that is the importance not only of what individuals can do, but the fact that we are part of larger systems and we need to understand how we as individuals navigate those systems, interact with those systems, sort of not only within the systems, but across the systems, and then making sure that we all are, cognizant of the impact of those systems on those individual level outcomes. So my last question here is about provider bias. So in this discussion around, health equity, there's been a push for addressing implicit bias. So this assumption that, we may be, engaging in biased behavior, but it's not explicit. We aren't as aware of it. Are there any successful strategies that you've seen to address not only provider, we can lump in explicit bias here too, but what successful strategies are out there to help providers address explicit and implicit bias, if you've seen any successful strategies?
I'm happy to start. I think that from my perspective, I throw it into a couple of different categories, right? So one, I think that as physicians, you see systems of care requiring and insisting that we as physicians do testing around to understand our own implicit bias. And I think I had mentioned that earlier. And I think those things can be helpful at an individual level in attempting to understand like what your own biases are, such that you can at least be aware of those things and work to address them in the way that you interact with not just patients, but maybe your colleagues, maybe the students and residents you train, like, and maybe in the way that you deal with family and other staff members at your own institution. So I think it's broader than just like your own biases and the way they affect your patients. It affects the way that you interact with anyone in your life. And so I think that that's one way. I think the other is looking at the way that we approach each other as physicians. So I think that an important facet for me, as someone who chaired a department, like who runs a urology practice and service, like is that patients need us as allies when we see that behavior on the part of others, when it's explicit, particularly, and implicit, and we need training and we need instruction on how to intervene in those situations constructively. Because at the end of the day, we're only going to change the hearts and minds of our other colleagues who we see that behavior in, if we can do that from a place of trust, if we can do that in a place that's constructive, and we can do so that we can alter the way in which they practice. Like, I feel like, we're not going to necessarily exclude physicians from practice, like who have some of these biases and even are overtly racially discriminatory. But what we can do as leaders in those institutions is begin to ally with our patients and colleagues to ultimately change behavior on a physician by physician, service line by service line practice every single day by identifying when those things are happening, by teaching our students and residents like how to intervene in from their positions, and being able to teach our colleagues about ways that they can change their behavior.
Mm-hmm. Joe or Sanford?
I want to add this, and I'm reminded of, some years ago, I'm a clinic coordinator, and I actually was the clinic coordinator for a prostate cancer clinic in a comprehensive cancer center. And one of the things that I advocated for with the team of urologists and oncologists, I said, if we truly want to address inequity, particularly as it relates to men of color and prostate cancer, we have to address the idea and topic of cancer before someone has a diagnosis. And I said it for this reason. We have to meet people where they are. And so one of the things that I really emphasized a lot was extending outreach and education beyond the clinic setting. When someone comes into the setting of the clinic with a diagnosis of prostate cancer, there's already a sense of anxiety, there's lots of fear. But if we can actually acknowledge the fact that, my goodness, even as it relates to screenings, there's inequity that occurs. And we have to meet people in the neighborhoods. We have to meet people where they are. This way, we actually begin to address distrust that is part of the reality of our healthcare setting today that we don't want to acknowledge because we are in the post-Obama presidency and we want to believe that we're post-racial. That is not true. I think that the current political climate exhibits a lot about inequity. More importantly, it exhibits a lot about the voices that are not heard. And so as it relates to cancer, I want to say this. We have to really begin to, first of all, acknowledge certain things, but more importantly, collaboration with our neighborhoods and our communities. It would truly begin to bring things to the surface that can address disparities, particularly around prostate cancer, screenings as well as treatment, in a way that can truly begin to be realized, as opposed to the surface discussions that have been occurring for the last 30 plus years.
Yep. Thank you. And Joe, any successful strategies around addressing implicit, explicit bias? Joe, you're muted.
For me, one thing that I work on, I wish a little bit more successfully, but I think is very important, is even changing the environment in which physicians or other providers see their patients. If leadership, physician and non-physician, sort of put resources in specific places, or if I'm able to be at the table to say, if we can resource this hospital or clinic that's associated with Cornell, this may change behaviors. If this place has, for me, a PET scanner, or has this kind of a therapy suite, or sees this kind of patient, or has these kinds of hours, I think it really empowers people to see them and be with them at the place and meet them at where they are, right?
And can I add one more thing, Reggie?
Okay.
Like if it's okay. And so I think that the other piece that we don't want to ignore is the lack of diversity amongst the types of clinicians that we see, right? And so, and I'd be remiss if I didn't at least speak to that when you talk about bias, because I think that first and foremost, when we think about Black urologists, like the percents are in the single digits, like, and the idea that we're going to provide equitable care with a homogenous or non-diverse workforce is, I think, a contradiction, right? And so I think the only way for us to truly get to a place where bias is not affecting our patients is if we have a diversity of voices and types of folks, not just racially, but from a sexual orientation perspective, from a gender perspective. Like we need those different voices to be a part of the healthcare system at the level of physicians, trainees, nurses, on down to EVS. Like I think the other piece is we need physicians to train and learn and work in diverse environments. And so I think that if you're at an institution where you're only seeing one type of person come through your door, that is not the place where we want trainees to be trained, frankly. And so we have to be able to be working with the very types of folks that are and working and living and interacting with, like, in order to understand, like how to treat patients better and to expose our biases as we're learning how to practice, rather than at a time when we're a fully minted physician now thrust upon our patients and communities of color.
Reggie, do I have time for one more comment?
I could spend the whole day talking to all three of you about this topic, but unfortunately we are running out of time. But I did want to give each of you 30 seconds to sort of give us your closing comments in our Ask Me Anything discussion. It can be based on any of the topics that we've talked about throughout the day here at the symposium, or just something that we've talked about in this session. So I'll start with you, Sanford. You can jump in with the comment you were going to make. So I'll give you 45 seconds. And then your closing 30 seconds.
I want to say it like this. I recalling very short time ago in March of 2020, we faced a pandemic, COVID-19, which is still around. But one thing that happened, the healthcare system shifted itself, and they began to address inequity in a way, not just telemedicine, but telehealth. But it was an acknowledgement of inequity in the system. And I would say that the examples of ways to address things started in 2020, when we recognized that there were many of our patient populations who had inaccessible care, and we were trying to think of ways to do it. And I would hope that we would continue to expand on the lessons we learned from 2 years ago.
Great. Joe.
So I'm going to use my 45 seconds to talk about the workforce, right? And because just reflecting on what I had said before, and also what Dr. Frencher was talking about, when I was talking about the regional cancer director who talked to me about imaging and where they work. Well, that was Robert Wynn, right? Who is the head of the VCU Massey, Black male, who was talking about these things, because we have to be present. Our workforce, same with radiology, low single digits, urology, low single digits. And so to be able to be part of the process of welcoming patients in, right? It's having being able to have the rainbow flag, or being able to, talk to patients about what my father would do, what I would do, or what my son would do, and have them understand the perspective that I'm coming from, right? And so I have to be there, right? I think it's very important. And I think, there are many members of different communities that need to be there too, but this issue in particular is the issue of my life. And so being there as part of that workforce, that physician workforce, is extremely important.
Agreed. Stan.
And I'll just say that, speaking directly to, if there's men out there who are watching this and who, are concerned about engaging with a health system that has historically been a challenge, has historically left us behind, understand that the first and foremost thing you can do is take your care into your own hands, work with your family and support groups and organizations like Zero Cancer to get the care you need. And to my colleagues, to my other urologists and physicians out there, we need to be the change agents to ensure that our patients have access to equitable care. And that's on us. Systems are only made of people. And at the end of the day, we have to have the agency to change the very systems in which we practice, with the goal of being able to take care of all men who come to see us. And me in particular, I'm interested in making sure that Black men have equitable access to care. So with that, I appreciate you having me here, Reggie. I too could speak all afternoon on these topics, and tomorrow again on Sunday at church.
Yes.
But
yes.
Thank you again for having us.
So thank you to Dr. James, to Dr. Osborne, and to Dr. Frencher. We had a whole list of questions. So as you can see, we could go on and on talking about these issues, but it was just so great to have this conversation, one with a panel of other Black men, so that Black men in the audience can see us. We have to be in the room in order for these issues to come up. And so, one, I appreciate your time. I appreciate your partnership with Zero, and I look forward to our continuing to work together. So as we wrap up today's symposium, I'm proud to announce Zero's Health Equity Individual Award. Congratulations to Mr. Jeff Fortson from Atlanta. He's a prostate cancer survivor and has been a passionate partner in spreading Zero's message about prostate cancer and health equity, connecting to partners in Atlanta, and also helping us to spread our message in the Southeast has been made easier for our team because of Mr. Fortson. Please watch the conversation with Mr. Fortson and our Health Equity Director, Chris Bennett, about this award. So please check out that conversation and all of today's award recipients at zerocancer.org/HE Symposium. And now I also want to tell you a little bit about Zero's Prostate Cancer Summit in Washington, D.C. So this event is the premier annual prostate cancer event, offering support, education, networking, and advocacy opportunities to empower those affected by this disease. It's happening in D.C. from February 26th to the 28th, and you can also attend virtually. And so you can sign up today at zerocancer.org. We'd also like to thank our sponsors for today's Health Equity Symposium. Specifically, our silver sponsors are Bayer, Blue Earth Diagnostics, Myovant Sciences, AstraZeneca, Sanofi, Pfizer Oncology, and Astellas. Zero is proud to partner with all of our sponsors on the many topics explored in our symposium today related to health equity and prostate cancer. So thank you again to those of us who are still with us, who joined us today in real time, or for those of you that are watching virtually. I just have a couple of closing comments to make about our symposium. I'll start with our definition of health equity. Health equity means that everyone has a fair and just opportunity to prevent, find, treat, and survive prostate cancer. And that means that we're going to have to remove all the obstacles, all the barriers that we've talked about today to a usual source of healthcare and to coordinated high-quality specialty care. And also ensuring that families have the resources to manage their health and navigate the primary and specialty care delivery system. Throughout our discussions today, it has been highlighted that the pathway to the disparities that we see in health generally and in prostate cancer specifically, that pathway is deeply rooted in the history of our country and the policies that created the segregated environments that we still inhabit. Our speakers today highlighted that the pathways to disparities are multi-level, and that the universal approach alone may not help us eliminate these disparities. We need to not only understand the federal level factors that have created the differences we see in prostate cancer outcomes, but also local implementation and outcomes. And this suggests that we need to focus on universal and local solutions. We were also introduced to a field that many of us may not have been exposed to before, cardio-oncology, and the importance of thinking about pre-cancer stress levels and the implications of prostate cancer treatment on cardiovascular risks and outcomes. We look forward to continuing to amplify the ABCDE approach that Dr. Guha mentioned. We also discussed today the disparities in clinical trials participation and the multi-level barriers that patients generally and that Black men and other racial and ethnic minorities experience as they navigate care and get connected to clinical trials. What I appreciated about Dr. Borno's presentation on this topic was the call to action for those designing clinical trials to remove barriers and not just focusing on what patients need to do and know. Another key topic that Dr. Borno raised that we on the health equity team at ZERO are very eager to explore is differentiating between genetic variation, ancestry, and race, and the need to better understand each of those terms and how they impact our health and how we navigate healthcare. The panel by the filmmakers was so inspirational and highlighted this new empowering tool to raise awareness. And these films are all part of our Prostate Cancer in the Black Community film series that was born out of our Health Equity Task Force. And we're starting that film series in Atlanta and eager to explore other cities. The initial response from the community has been incredible, and we look forward to screening these films to amplify the experience of Black men and prostate cancer in many other cities. Now, across these presentations, the importance of thinking and acting across multiple levels was a common theme today. Individuals, community, healthcare systems, various levels of government. And it's important that we not only ask, what can individuals do, but also what can the systems in which those individuals are navigating do better as well. We at ZERO look forward to continuing to raise awareness about the differences in prostate cancer, educating our community about what we all can do as individuals, in our roles as healthcare providers, healthcare system administrators, community members, researchers, advocates, citizens in our cities and in our country. And at each of those levels, we can be champions for equity and ensure that we don't come back here year after year for this symposium and see no difference between the experience that Black men have and other racial and ethnic groups have as they navigate their prostate cancer journey. While our overall goal at ZERO is to zero out prostate cancer for everyone, until that happens, we have to focus not only on a universal approach, but also a targeted approach for those most impacted or most at risk. This ensures that we all cross that finish line of zeroing out prostate cancer together for everyone impacted. So thank you so much for attending ZERO's second annual Health Equity Symposium. All of today's content will be available on demand on ZERO's Facebook and YouTube pages, as well as at zerocancer.org/health HE Symposium. Thank you again and have a great day.